Hello everyone, welcome to Dental XP. I'm Dr. Omid Muqaddas. I'm a periodontist and currently I'm the assistant professor at the Department of Periodontology and Implant Dentistry at Tehran Azad University. The case that I want to demonstrate to you today is horizontal ridge augmentation simultaneous with implant placement using titanium mesh. And the case that we're going to talk about is a 35-year-old woman. You can see the lateral is missed. The patient has lost the central incisor. The level of the gummy smile is apparent here. And what are the problems that we may face? Well, the thickness of the soft tissue is not bad, but we can see the uneven gingival margins in the area that the patient has lost the tooth and the area that the patient has a tooth, tooth number 8 compared to tooth number 9. Here we're facing a short clinical crown, so we can have a crown lengthening here to make it more proper, and at the end the patient should have some restorative work to make this canine more look like this lateral. This is the occlusal view of the soft tissue. You can see the depression here, and this is the CBCT scan of the patient. You can see in crestal area the bone width seems to be good, but with about 2 to 3 millimeters below that we're going to face this deficiency. And according to the previous slide as I presented to you, you can see the level of the soft tissue which is different on tooth number 8 and the area of tooth number 9. So, should we place the dental implant due to simultaneous augmentation? Well, we should place the dental implant in the area that it should be, not in the area where the bone is. So where we should put it, usually centered to the palate, under the cingulum area of the central, and we can compare it to the adjacent central also. And then we can build up this contour and this tissue, wait, and come back for prosthetic approach. Here, after doing some infiltration, we're going to begin the evaluation with periodontal probe to see exactly where is the level of the interproximal bone, because what is very important for having the future papilla is the presence of the interproximal bone, according to the famous article by Ule Grunder in 2000 International Journal of Periodontics and Restorative Dentistry. We have enough interproximal bone. Our plan here is to start with a crestal incision and then having a vertical release incision to achieve proper coverage for our grafting. This is the crestal incision. We're going to do it exactly mid-crestal. It's very important for us to completely and very minimally invasive remove this soft tissue which is depressed here according to the usage of a improper flipper by the patient. We're going to reflect the papilla. Well, in this case, because of the amount that we're going to augment, I couldn't utilize papilla saving incisions, but it's recommended if we can do it, because when we don't reflect the papilla, we are reducing the risk of bone loss according to that reflection. So you can see I only used one release incision to have enough access, because with having 2 releasing incisions I'm compromising the vascular supply to the grafted area. You can see the depression here. The width at the crestal area seems not to be bad, but at about 3 to 4 millimeters apical to that, we can see that depression exactly as the one that we had on CBCT scan. You can see the depression, and I'm gonna very little reflect the palatal flap to make sure that I'm placing my dental implant in the exact position in the cingulum area of the centrals. We should have enough bone at the buccal In this case, we can have, according to the radiography that I presented to you, enough space between tooth and implant, and also in a functional position the dental implant should be, which is in central incisor of the maxilla, is in the cingulum area. Parallelism also is very important. We're going to drill the case with about 12 millimeter of height, and the dental implant that I'm going to insert in this case is a 3.4 millimeter by NeoBiotech. You can see after placement the dental implant, this is the deficiency that we have. We should actually build this gap here with bone. The dental implant is in correct position according to the cingulum area of the centrals. Parallelism is correct. We're going to check the occlusion of the patient. We're going to check the level of the soft tissue. We're not going to place wherever the platform of the dental implant wherever the bone is. You can see here when I bring the soft tissue up, this color of this parallel pin shows me that I have enough coronary advancement of my flap or not. For this, for more information on this topic, you can go to Dental XP website and a great presentation by Dr. Vizcaya at the 3-2A rule presentation. So we're going to place the dental implant motor driven. We're going to check all the time of its placement, the direction and the distance and the angulation of the dental implant, not to be influenced by the palatal bone, and push it to the buccal. After finishing placement of the dental implant, we're going to go for the augmentation. Here in this case, I used a freeze-dried bone allograft, which is a low turnover rate bone graft, because I want my scaffold to be there for at least 4 to 6 months. And we're going to use tie mesh. What is the advantages of the tie mesh? Well, titanium mesh is not a membrane. It's a rigid barrier which is going to maintain this space for us, and which is very important for bone formation in that specific period of time. In this case, I used the titanium mesh design by NeoBiotech. It has different shapes for 1-wall defects, 2-wall defects, 3-wall defects, for palatal, for buccal. And before I placed my grafting material, I also provided some distance for biologic width for the tooth number 8, because as I presented to you, we had short clinical crown, as you can see at the left part of the screen in the slide. I'm going to release my flap before placing my grafting material first, and make sure that I have a tension-free flap advancement. Then I'm going to place my grafting material in the area of this concavity. You can see the grafting material here. I'm going to shape it. I'm going to usually, in all my augmentations, I'm going to do a little bit of overfilling to make sure that I can reach the amount I need, which is going to be something around here. This is the type of mesh that I'm going to use in this case, which is the A2 type of mesh. You can see these projections. We should bend them, and they will cover the graft, and we're going to fix it with a cover screw or healing abutment, or using the flat abutment of its system. After placing the grafting material and after shaping the mesh in the area to completely grab the grafting material, we're going to place a dermal graft here. I place a dermal graft for increasing the thickness of the tissue, and also for reducing the risk, possible risk, for soft tissue fenestration that may happen usually. What is also very important to notice, which is in all cases it should be done in placing the resolvables, non-resolvable membrane or meshes, that the mesh or membrane should not be in contact with the tooth. We should have a distance between them. So now we're going to check again the flap advancement. This is the dermal graft that I'm going to put at the buccal aspect of the flap, which I have a thin tissue, and that's the area that I have the concavity, and soft tissue follows the form of the bone, so I want to increase the tissue thickness also in that area over the augmentation or over the augmented bone. After placing the membrane there, the dermal graft there, I'm going to start to close the case with vertical mattress lock sutures. This is the suture of choice for me. For those of you who heard me lecturing before, you may hear it many times. I'm going to insert my needle from the buccal flap with about 3 to 5 millimeters from the margin. I'm going to pass it through the palatal flap. Then I'm going to insert again through the palatal. The 2 points of insertion should have at least 3 millimeter distance with each other on each side of the flap. And then going out again from the buccal flap with at least 3 millimeter distance between 2 insertion points. And then this is the simple vertical mattress. Then I'm going to pass my needle through the loop in the palate, and this will be a modified mattress or vertical mattress lock suture. The point is, not only I'm going to achieve good adaptation of my flap, but also with only one suture, I'm going to achieve the primary closure also. In this case, I utilize 2 vertical mattress lock sutures at the mesial aspect of the canine and mesial aspect of the central, and then some interrupted sutures in between to make sure the complete adaptation of the flap, and finally close the releasing incision. How much time should I wait for this grafting material to be mature? Well, the regeneration usually takes time for about 6 months, so I should wait for 6 months. Then I'm gonna remove the mesh and place the healing abutment to form the tissue, and we're gonna check if at that time another soft tissue grafting is necessary or not. This is a second vertical mattress lock suture that you're seeing, and then we're gonna have some interrupted sutures in between. This is how the case gonna end. I used here 4/0 silk sutures, the conventional approach, and as I told you, we're gonna wait for 6 months for bone grafting to mature completely. And thank you so much again for joining me on dentalxp.com. Bye bye.